Here we go. Good evening, everybody. We are live. It is Wednesday evening, 8 o'clock, so we are live today. We are discussing cysts and fibroids. I will just wait a couple of minutes for everyone to join. Welcome, Healthy for Being. Thanks for always supporting us. I always see you around. We will just wait for the few to get our notification that we've gone live. So today is Zahn van Rijn. Welcome. Just give it a couple of minutes. Okay, there we go. And we've got Dr. Oosthuizen. Good evening. I've got Machin Maseko, and we'll just give it a few minutes. Okay, so thanks, guys. Okay, so I desire Juju. Thanks for joining us. Like I said, we're just going to give it a couple of minutes for everyone to join. Adele, Mary, welcome, guys. Welcome. It's Wednesday evening, 8 p.m. It's our time. And we are discussing cysts and fibroids. Tonight we are chatting to Dr. Oosthuizen. She's from Cape Fertility. So I will just accept. She's sent a request. So we'll welcome. And we'll wait for Dr. Oosthuizen. There we go. There we go. Hi, Dr. Oosthuizen. How are you?
I'm good, thanks. Can you hear me?
I can hear you perfectly. Perfect. Everything's great.
Awesome.
Thank you and welcome. And thank you for joining us this evening. And it's always great to have you here. It's always great to have any of the fertility specialists around to discuss with them, chat with them and things. I always remind the ladies that, we can't, it's expensive to go to fertility specialists. So we have to be so grateful when a specialist takes the time out to just chat to us and give us some advice. It's free advice basically for everyone that's listening. So guys, take advantage of this. And I see quite a lot of you have joined now. And okay, numbers are going up, so that's absolutely great. Thank you, Dr. Oosthuizen. Dr. Oosthuizen is a fertility specialist at Cape Fertility Clinic. So those of you that are in the Cape Town area, she would be the doctor, doctor to go and see in Cape Town. But I think you do get a lot of international clients as well, or patients as well, that deal with infertility. So yeah, I can't wait to hear about cysts and fibroids. I'm always very confused about fibroids. It doesn't come from endometriosis. How does it, what was the connection there? So we will leave it to you to explain to everybody. We have a few questions at the end of the talk, and I'm sure you'll be able to assist us with that. So thank you again for joining us, Doctor.
That's an absolute pleasure. And I don't think it's just you who struggles to understand what to do when you've got fibroids and when you've got cysts. This is something we encounter all the time with our patients, and quite frankly, there's a lot of controversy around how best to manage a lot of these issues. So I'm going to run through a couple of the basics of what they are. I'm going to start off with fibroids just because it is a much bigger topic versus cysts. When it comes to cysts, they're the ones we are most commonly going to see, and the ones we're going to send off to see an oncologist because we are worried. So that's going to be a lot sort of less stuff to unpack from that side. So I'm going to start off with fibroids. And what a fibroid is in fancy terms, we say it is a monoclonal smooth muscle tumor. What that basically means is the muscle that forms the part of your uterus that can contract. So the thing that gives you pain during labor, the thing that that can give you pain during your period, that actual muscle in the uterus, you get a little growth. Now, the minute I say growth, everyone goes, and they freak out and worry that it might be something cancerous. We're not worried about anything cancerous with 99.9% of the fibroids we deal with. So what it is a little growth, and it tends to look like a ball. And if you see it on an ultrasound, your doctor will actually show you that perfect little ball. It looks like a tennis ball, and they can vary in size. And they can vary as to where they are in the uterus. So you can't compare one fibroid with another and say apples with apples. They can be completely different things. And what they mean for you might be different, and what they mean for your management and fertility and just everyday gynecological life could be completely different. So essentially, it's this little ball, it's got a nice little capsule around it, and they tend to grow. Now, who gets these fibroids? That's quite an interesting thing. We don't really know why certain women get it. There are a whole bunch of things we know put you at risk of getting them. So delaying pregnancy until much later in life can put you at risk of getting them. One of the bigger things is actually genetics. So if it runs in your family, you might be more predisposed to getting fibroids. We know as you get older, you're more likely to get fibroids. So some scary stats is by the time you're 50, most women are going to have fibroids, so about 70 to 80% of women. And that's going to vary according to where you are from, your ethnicity, quite frankly, just your race. White women are going to be about 70% of them will have fibroids. In African women, about 80% of them are going to have fibroids. And what we know, especially at Cape Fertility, working with a lot of patients from the Congo, from Angola, from Nigeria, it seems to be the more north you go in Africa, the more dominant the problem of fibroids is. And whereas your average 30-something-year-old who comes into your practice here might not have so many fibroids, I know every time I see a patient from a bit higher up in Africa, I'm always worried, where are those fibroids and how big are they? Because women from a bit more north in Africa tend to grow bigger fibroids and a lot faster at a younger age. So we tend to need to remove them a lot more often. So you've got your family history, your age, what's happening in terms of your reproductive career that can put you at risk of getting them. But that does not mean that you can't walk in as a 20-something-year-old woman with fibroids. It doesn't mean that it's only going to happen much later as you age. It also doesn't mean you need to worry if you are later on in your reproductive career, so in your late 40s, approaching 50, and you've got some fibroids. That's quite normal. So the other thing we want to know about fibroids is, where are they in a uterus? So if you imagine your uterus, and I'm kicking myself for not bringing home my little model of a uterus so I can actually show you guys. But if we imagine a little uterus that is sitting obviously happily in your pelvis and it's going to grow this little fibroid, it can be in 3 very different places. So the place that we talk about would be if it is in the lining. So the lining that you shed every single month with your period, if you're having periods, that can be one place that the fibroid can grow, and it can be completely in the middle of your cavity, or it can be partially in that uterine cavity and partially in the muscle. You might have a fibroid that is completely in the muscle of the uterus, and you might have one that's sort of hanging on the outside of the uterus and sort of dangling into your pelvis. Now, where the fibroid is going to mean very, very different things. If it is squashing your lining or in your lining, it is probably going to give you a lot of symptoms in terms of heavier periods, more painful periods. And the easiest way to think about it is if you have a set, and excuse my horrible little image of a uterus, a set area that you're going to bleed from. The minute I add a fibroid to that, I'm probably going to increase the surface where you can bleed from. So you're going to bleed a lot more. So one of the most common symptoms we hear is, my periods are heavy and long and I have clots. So that might be a warning sign that you have fibroids. You might also have more painful periods because you've got this fibroid sitting in your cavity and your uterus is trying to contract during your period and get rid of all of that blood and clot that's in there, and it's contracting down onto that fibroid. So you might also have a lot more pain and cramps if you do have fibroids. Now, if that fibroid isn't actually touching the lining and it's sitting in the middle of the muscle, so just minding its own business, and it's small enough there, you might not necessarily have a lot of symptoms. If it gets bigger, and you imagine that the muscle of your uterus, for example, is this size, and you now grow a fibroid that's that size, it's obviously going to start squashing your lining, and it can start compressing the lining and causing symptoms. The bigger a fibroid gets, the more likely it is to cause symptoms such as pain and abnormal bleeding. And you can even get monstrously large fibroids, and it's something that we see a lot more commonly in the government sector, and it's really not uncommon for us to actually literally have to cut women from, belly button all the way up to remove these monstrously large fibroids. So just because they're growing on the outside of the uterus doesn't mean they won't cause symptoms. Sometimes they can get really big and take up space inside of the tummy. They might start squishing your bowel, and they might give you difficulty going to the toilet. They might squash your bladder, and you find, oh, I just can't hold my bladder for very long. I'm constantly running to the toilet. Or it might just be a heaviness that you're aware of inside of the tummy. So you're constantly aware of this feeling of something growing inside of your abdomen that might get bigger, your pants are getting a little bit tighter. So there are a lot of different ways that a fibroid can present. Also, there's the chance you go and see your gynae or you're seeing your fertility specialist and suddenly they find a fibroid. You've had no symptoms, the periods are fine, you feel great, and we find a fibroid. So that's obviously an incidental finding, and that might then have some repercussions for if you are trying to fall pregnant or if you are suffering from miscarriages. So I always like to think of women with fibroids in three different groups, and they might overlap a little bit, but the women who come in saying, I have fibroids and I have symptoms, the women who have fibroids and problems falling pregnant, and the women who are having miscarriages with fibroids. So the miscarriage thing is a bit more controversial, and that's why I say it's really an interesting topic, and it's not really clear what we should do, because a lot of the time we're not sure if removing a fibroid is going to change what's happening with a miscarriage. But I'll get back to that when we start talking about all of our management options that we have. So when we need to make the diagnosis for a fibroid, sometimes you might be able to just feel it. So if your doctor's feeling your tummy and they can say, oh, I can feel your uterus is a little bit bigger, we might be able to feel the fibroid. Sometimes on an internal examination, because your fibroid can actually sometimes hang out into the vagina through the cervix, you might even feel a fibroid that way. Other times it might just be with an ultrasound that we can pick up the fibroid. And there might be different types of ultrasound that your doctor wants to do. So we all know the routine, I believe everyone calls it Wonder, the internal ultrasound that you often get at the gynae, where we have a good look at the uterus. There might be an obvious fibroid that your doctor can show you on that scan. We might want to do what we call a saline ultrasound, where we actually put a little bit of fluid inside of the cavity of the uterus and do the ultrasound. And a lot of the time we do that just so we can see how much that fibroid is actually impacting on the lining itself and denting the inside of the cavity. We might want to do 2D scans, 3D scans. We might even go as far as an MRI. So if a patient has a uterus full of fibroids and the doctor who's examining the patient can't tell which fibroid is where and what's impacting the cavity, which one is the largest, which ones do we need to take out, how much actual normal tissue is there, we might want to do an MRI as well. So there are a lot of investigations we're going to do to try and understand how many fibroids there are and where these fibroids are. Are they explaining your symptoms, and do we actually need to do something about them? So once your doctor has said to you, great, there are fibroids, we know they are there, does that mean you need to have surgery? Does that mean you need an intervention? Not necessarily. Remember that fibroids are going to affect women throughout their reproductive career. So if you are 46, 47, menopause is not too far away, you've got horrible sort of periods at the moment, find a fibroid and we put it down to that, your management is going to be very different to a woman who wants to have babies or a woman who is much younger. So we need to try and decide what the best form of therapy for you would be. And there are a couple of things that we take into account. So we want to know where the fibroids are. So are they inside of the lining? Are they squashing the lining within the muscle of the uterus? Are they sitting on the outside of the uterus? How big are they? Many of the little fibroids are about 10 millimeters in size. Those are probably not going to cause much of a problem unless they slap bang in the middle of your cavity. So we want to know how big they are in terms of if we were to operate, what are we going to be taking out? We want to know exactly how many there are, because if we are going to operate, it's going to determine how we do our surgery. It might also be a decision of some of the times we want to take out a couple of the fibroids, all of the fibroids. So we want to map that out in advance. We want to know your age and how close you are to menopause and where you are in your reproductive career. Are we planning children? Are we in the battle with fertility and trying to get pregnant? Or is that all behind us and we're looking down the road at menopause? Also, I want to know how safe is it to do any of our interventions. So is there a medical reason that I can't give you any kind of therapy? Is there a medical reason I don't want to operate on you? Is there a surgical reason? Have you had multiple surgeries and it's just not safe for me to want to go and operate? Then I'm going to be far more conservative in what we do and how we do it. Also, we want to chat to you, our patient. We want to know what your symptoms are and what your preference is. Some patients would say, well, I've got these symptoms, you're telling me it might or might not get better with surgery, I prefer to try surgery. Other patients might say, well, you're saying surgery is a great idea, but I don't really want to have surgery. I'd rather try other things first. So we need to take your decision into account as well. Because remember, your doctor is there to give you the information they know and make sure that you have the same kind of knowledge base that we do, so we make decisions together. It's never a dictatorship. So in terms of what you can do medically, the really tricky thing with trying to manage fibroids medically is I'm trying to manage your symptoms. I can't manage the actual fibroid. So there's no magic drug that I can give you that's going to, I'll say this in inverted commas, no magic drug that's going to just shrink those fibroids and get rid of them, and that's it. You take them for a couple of months and we're done. Unfortunately, it doesn't work that way. It's kind of like when you have a cough and you go to the doctor. There are a whole bunch of therapies that your doctor will give you to try and manage that cough, but the underlying condition is still going to be there. So just because we manage the cough from asthma doesn't mean we've cured your asthma. It's the same kind of concept. So if your fibroids are causing a lot of bleeding, we might want to find different ways to try and decrease your bleeding. That might be in the form of anti-inflammatories. So commonly we can use something like Brufen before the start of a period, a day or two. You start taking them and it might decrease the amount you are bleeding. We could also give you something called cyclocapron, which is quite commonly used to decrease the amount that you are bleeding. We might try a different strategy to try and get rid of the period. So for example, putting you on an injectable contraceptive that can usually end up putting you into what we call an amenorrhea, so not having a period, or even a contraceptive pill to try and decrease the amount you bleed and cycling you so you don't have periods, so that you're not having symptoms of bleeding and the pain that comes with bleeding. So we're not going to shrink those fibroids and get rid of them, but we're going to manage the symptom. And that's a great idea if you're not trying to fall pregnant, because obviously a contraceptive is not going to be an answer if you're trying to fall pregnant. It's a great idea if you're close to menopause and you're trying to buy a little bit of time. It's a great idea if you're not the best candidate for surgery. But quite often we're not going to get the response we really want because we're not tackling the root problem. So then we start thinking of other different medical therapies that there are out there. And there are two other medical drugs that we can talk about. And the one is something that we use to down-regulate the pituitary, which is a little gland in the brain that controls what's happening hormones-wise. So it sends the signals to your ovaries and tells them what to do. So we can use one of the GnRH analogs, and it basically stops you having a period. What we know about this is we've proven we can shrink fibroids with time. So that's why I say there's no magic cure in inverted commas, because there are drugs that we can eliminate.
I think on the last talk we did, you spoke about the GnR drug. I think it was one of the other things as well. So I've heard this before, yes.
Yeah.
Okay.
So there is this formulation that we can use, and we can also give it as sort of a 3-monthly thing, and it's going to take away your periods. The problem is putting you basically into a menopause. And that's obviously not something we can do long term because it's not great for your bones, it's not great for your cardiovascular health. Symptom-wise, you're going to get hot flushes. So we're going to have to add back some hormones, so something like estrogen and progesterone to give you a little bit of that extra hormone so you don't feel like you're walking around with a permanent hot flush and feeling menopausal. I know that's going to shrink your fibroids over time, but I know this is not something I can put you on for the next 5 to 10 years until you do go into menopause. So it's a short-term option. And the time it's most beneficial is when you've got these massive fibroids and we're waiting to get you into surgery because there are long waiting lists, or I'm worried that if we operate, you're going to bleed terribly. I might want to try and shrink those fibroids over 3 to 6 months to make the surgery easier and maybe choose a less invasive option. So we're going to run through the different types of surgeries just now. But what they might do is turn a big cut in the tummy into a much smaller cut, or even a laparoscopic surgery, or a multiple hysteroscopy surgery procedure where we have to remove the fibroids just to a single one. It's less likely to have you bleeding, and we think it generally makes a big difference in terms of your recovery. It's not going to be an option for women who have a normal size fibroid that we can offer routine surgery and management to, but it's something to consider for those bigger problem cases when we're trying to make them more manageable, or if we're waiting a long time. For example, at the moment with COVID in the government sector, there are really long waiting lists for surgery. If we can't do surgery in the next 6 months to a year, this might be an option to buy us some time. But it's not going to be your long-term solution, unfortunately. Then there's another wonderful drug, called Euler Crystal, which is not available in this country. And it has recently been pulled off the market in other countries because there have been some concerns about safety. It is a very, very well-studied drug. It's got a lot of different uses. It came about, we were talking about it in terms of termination of pregnancy, not termination, sorry, trying to avoid falling pregnant. So instead of like a morning after pill, it can be quite effective. But what they did notice is it shrinks fibroids, and it shrinks them quite quickly, and it shrinks them and keeps them small for a lot longer than that GnRH agonist does. So with your GnRH agonist, what can happen is we give you the meds, we shrink that fibroid, we stop the meds, the fibroids grow back again. The Euler Crystal tends to shrink them for a little bit longer. It gives you far less side effects. It's a lot less detrimental to your bone health. You don't really need to add back too much with it. So it's a drug that we don't have available, and it's a drug that's been taken off the market to investigate a little bit more. I think there were problems with some of the liver tests that were coming back with this drug. Hopefully it will come back and it will be available, because it looks like a great option, not only for shrinking fibroids before surgery, but managing conservatively how we're going to go about shrinking those fibroids. And then we're doing a lot of interesting work where you would take it for example 2 months and then off for a month, take it for 2 months, off for a month. And you could cycle your way through that and try and control symptoms from that point of view. So those are most of the medical options that are there. A lot of not long-term things that can buy us time from a medical point of view, and then the managing of the symptoms. So what happens if medical treatment isn't working, or if we say, right, actually, I think this might be interfering with you trying to fall pregnant, let's go and operate. What happens then? Well, then we've got to decide how are we going to operate. And a few things are going to dictate that. If that fibroid is sitting slap bang in the middle of the cavity where we want the baby to grow, those are the one type of fibroid that most doctors will agree should come out if you want to be pregnant. If the fibroid is sitting in the muscle and it's not actually touching or distorting the cavity, so if you imagine that's one of the walls of the uterine cavity, if you've got a big fibroid, which is my fist, if it starts denting in like that, we don't like that sort of thing. So if that fibroid is sitting there denting the cavity, we probably would want to take that out as well. If it's quite innocently sitting in the muscle, not really doing very much, we'd probably be more inclined to leave it. And if it's sitting outside of the uterus, it's probably not going to impact your fertility at all. The main reason we would take a fibroid that's sitting on top of the uterus or sitting outside the uterus out would be if it's causing you pressure symptoms, or if it's really big and we think, well, it's just taking up so much space, let's take that thing out. So for fertility, your primary concern is it touching the lining or is it squashing the lining? And then there's this whole big gray area of how big does the fibroid that's sitting straight in the middle of the muscle of the uterus not touching the lining need to be before you take it out. But that's a discussion that you tend to have based on your clinical findings in your clinical situation and what the surgery would mean for you. So if that fibroid sits slap bang in the middle of the uterus, that's one of the best case scenarios. If it is small enough, we can actually remove it hysteroscopically. So what that means is a procedure where we usually sedate you. Some places won't sedate you, they do just in the office, but most people tend to actually give you some kind of sedation or anesthetic to do this. We pass a little scope inside of the uterus. We go straight through the cervix, which is the thing that opens when the baby is born. So we're not cutting through to get anywhere, just naturally using those openings to put a little camera inside. That camera, if I'm going to take my pen and we're just going to imagine this is that. It's got light coming out because obviously the uterus is a dark cavity, so we want to light it up. It has fluid coming out of it, so I can expand that uterus and actually see everything. Otherwise, it just sits all collapsed. And it's got a little suction where I can suck out some of the fluid, and we've got little operating ports. It's connected to a camera so that I can see everything I am doing. So your doctor should be able to take a video or take a few images of what you're actually seeing. And we've got various different instruments we can use. I'm not going to run through all of them in this talk, but there are multiple different ways to actually go and remove a fibroid that is sitting there and sticking into the cavity. So you can do that, sometimes one procedure, sometimes two procedures. You can remove most of that fibroid. You get up, carry on with your life. You don't even really need much downtime, probably just that day if you've had an anesthetic, and you carry on with your life. What we have to take into consideration is how many fibroids are there and how skilled is your doctor. So some doctors would be more skilled, some doctors less skilled in taking out fibroids. It's something fertility specialists tend to specialize in, so it's something we can do quite swiftly. And with all the different types of instruments, we can try and get it done in one go. What we might want to do is say, let's look again with a second hysteroscopy, so camera back inside of the uterus in a few weeks' time, just to make sure that cutting out that fibroid hasn't left any scar tissue behind and that cavity is beautifully healed. But that can be a really effective way to surgically remove the fibroids. And is a laparoscopy. So I'm sure most people have heard of the keyhole surgery, which is a camera through the belly button and usually a few smaller cuts. So you don't actually walk away with that big sort of zip line cut or that Caesar scar cut. That's the best option if you've got few smaller fibroids. We don't want to be taking out massive things through that kind of surgery. We don't want to be taking out multiple fibroids through that kind of surgery. And there are a couple of reasons for that. Number one, whenever we cut into the muscle of the uterus, so we've actually opened up the uterus, taken out a fibroid, and we stitched it up in layers, that automatically means 3 months, not trying to fall pregnant at least. We don't want to test that scar, so you have to heal for at least 3 months. It also means
you've actually just, sorry, you just answered one of the questions because one of the ladies just asked, yeah, how long after surgery? So
yeah,
3 months. Great.
really sort of generous with us and say at one point started training, it was, oh, we don't want to do this for like 8 months, then we don't want to do anything for 6 months. Now 3 months we let that wound heal and then we're happy. In terms of future pregnancy, you've got to treat this as if it was a very bad Caesar. So you need to, any pregnancy after a fibroid is removed, you need to have a cesarean section. This is not a debate about once you've had a Caesar before, can you try normal birth? Because that is possible. We've cut into the top muscle of your uterus where it is the most vulnerable, where it is stretched a lot in the pregnancy, where I'm now asking it to contract in a normal delivery. We don't want to test that scar. If that scar is, that means baby is probably dead and your life is at risk and your uterus. So you need to be very clear from the start with your uterus, and we take out a fibroid through that laparoscopic surgery, big cut in the tummy. I'm not talking about the hysteroscopy inside of the uterus, only actually cutting into the muscle and up afterwards. You will need a cesarean section in future. So when your doctor is going to decide how to do the surgery, it's going to depend on what skills they have. Not all doctors can do a laparoscopic myomectomy because you need to be able to stitch. And stitching is very easy to do as a doctor when something's in front of you. It's a lot more complex when you're doing it laparoscopically. You need to be able to stitch close that defect where we've actually pulled out that fibroid. And you need to be able to stitch it up very well and stitch it up in layers. So it's not just a case of a stitch or two, stop bleeding, and you're happy. It needs to be very well protected. The other thing we always need to think of is how am I going to get that fibroid out of the body? It's a nice big cut, just take it out. And this is where controversies happens when it comes to laparoscopic removing fibroids. There was a big, for a little while, we use something called a morcellator. Now, a morcellator is quite a handy instrument. What it does is we pick up the fibroid and it basically chomps up this fibroid and removes the tissue, and basically like a long sausage. So if your doctor does this for you, they should be able to show you the histology pictures of this thing that looks like a long sausage, which is your fibroid all ground up. Now, there is going to be a certain proportion of fibroids that will be cancerous, called a sarcoma. It is incredibly rare to have a cancerous fibroid. So I don't want everyone with fibroids to go, what if they're cancer? It's very, very rare. I remember seeing some stats about 1 in every 400 fibroid surgeries that are done would have a sarcoma, so the cancerous form of a fibroid. People who are more likely to have the cancer would be the women, postmenopausal women who get a fibroid that suddenly starts growing and causing symptoms. And we're always more worried about a single fibroid in an older woman than multiple fibroids that we know have been there for a while. What we don't want to do is take that morcellator and basically spin the fibroid tissue everywhere, and we're spreading cancer everywhere, all over the tummy. So your doctor is quite comfortable that we're not dealing with a cancer. So not many people would use a morcellator in a patient close to 50. I think very few would do it, or they might morcellate inside a little bag so there's no spill. But in your younger patients in your 20s, 30s, and early 40s, we're quite comfortable to use the morcellate as long as your doctor is experienced in using it and not spraying tissue everywhere. That's also why we're always going to give a bit of the fibroid to the lab to have a look at and tell us that it's not cancerous. But remember, this is the teeny tiny drop in the ocean that is cancerous. So it is very, very uncommon that it is actually cancerous. So if your doctor can do a laparoscopic surgery, that's great. You tend to recover faster. You can go home sometimes the same day, usually the next morning. Your recovery is so much faster because you haven't had that big cut. And you can get up and get going and carry on with your life quite effectively. Also the bonus of not having the big scar. If there are too many fibroids and they are too big, then there's no point trying to do that surgery laparoscopically. Then we are going to do what we call a mini laparotomy usually, which is a teensy tiny cut, smaller than a Caesar cut. We actually then will remove all the fibroids and stitch them by hand. Sometimes if you do have one of these monstrously large fibroids, and I mean, I've seen them go all the way up to the diaphragm, then there's no way to avoid doing a very big cut. But that's the exception. Most women are going to have very small fibroids that are quite easy to remove. The nice part about that surgery, obviously no morcellates are involved. We know we're stitching up everything very nicely. It's very easy. You can have a lot more doctors who are skilled at doing it. The downside, it's a longer stay in hospital, 2 or 3 days to recover. You've got the wound, which remember we're going to go through anyway when you have your Caesar one day. But obviously that wound takes a little bit longer to get you going because it is a bigger operation. So there are definitely benefits to doing laparoscopic myomectomies, and it's the way fertility specialists tend to go because we like our patients up and recovering fast, but sometimes we just can't, and we have to then resort to what we call an open myomectomy to remove all of those fibroids. So those are most of the surgical options. There's also the option of you saying, I'm finished my family, I'm sick of this bleeding, I don't want to deal with fibroids anymore, just take the whole thing out. And you can have a hysterectomy. So that's not going to apply to a lot of the patients wanting fertility, obviously, but that is an option. And there is also the option of something called an embolization. Now, that is done in a radiology department. You're sedated when they do it. They used to go through the groin blood vessels. Now I believe they're going through your blood vessel and they feed a little catheter into that artery that supplies blood to the uterus, and they drop off these little particles that block it off. So you're basically causing what I would call a heart attack in that uterus. You cut the blood supply to those fibroids. The uterus itself doesn't rot or die or anything like that, but we're starving these fibroids that need blood to grow of that blood supply. Now, that can be a really good option for some patients. If your fibroids are really big and they're causing pressure symptoms where you feel I can't go to the toilet properly, it's squeezing my belly, my pants don't close, my bladder is uncomfortable, that's not going to be a great option because remember, I'm starving those fibroids of blood. It's going to take a very long time for those fibroids to start getting smaller and smaller and smaller. They might never go away. They're probably just going to shrink over time. So that's not going to be a great option for your pressure symptoms. For your bleeding patients, it can be a very effective option because we can actually stop that horrible bleeding, reduce that horrible bleeding quite nicely. The patients we don't like it for, patients who want to be pregnant. There are obviously going to be exceptions because sometimes surgery just isn't an option for those patients. But we don't like it because, number one, we think if you've got such a big fibroid sitting there, and I'm not actually taking that fibroid out, I'm just trying to basically kill it so that it doesn't get worse and it doesn't cause that many symptoms, it's still going to sit there and potentially cause problems with miscarriages and pregnancies. Also, when we drop off those little particles, some of them might travel off to the ovary and we might drop your ovarian reserve, which is not a great thing if we're trying to get you pregnant and we're trying to do IVF. We also know that we might starve the blood supply to a uterus that I now want to nourish pregnancy, grow a placenta. So we know that you are more likely, if you are pregnant after an embolization, to have miscarriages, to have babies that don't grow well, to have placentas that implant improperly and cause a lot of bleeding and problems. And your chances of having a baby born very early are very likely. So it's not the go-to option for somebody with miscarriages, somebody who's trying to fall pregnant. It might have a role in those patients when they got massive fibroids, and I'm talking about the kind that I haven't removed since state sector, where you've got these 15, 20, 30 centimeter massive fibroids, and you don't want this patient to bleed to the point of losing her uterus. You might cut off blood supply then. So your doctor might talk to you about doing it right before surgery to try and decrease bleeding, but that's usually not going to be in our fertility patients as a first line. And you might read about ultrasound or MRI, where we can use the heat to try to kill off the cells in the fibroid. It's not very widely done. You have to be sedated to do it. There are a lot of risks that come with it, and it's not the most effective form of therapy. So not many people are doing that. You probably won't find a lot of it here in South Africa. It's more sort of UK based, more for very small fibroids. So just so I don't lose everyone, because I know I talk a lot, we've talked about what fibroids are, we've talked about some of the symptoms, how we're going to diagnose them, and how we're going to decide medical, surgical, and the different types of surgery, or the uterine embolization, or even removing a uterus. Now, what most of the listeners are going to be interested in is, does this impact on my fertility? Does this impact on having miscarriages? And when it comes to fertility, it depends where that fibroid is. So as I've briefly explained, if it is touching the cavity, in the cavity, squashing the cavity, your doctor is going to be more likely to want to remove it. If it is sitting outside of the uterus, we're quite comfortable to leave them and not do anything. And there's that gray zone of that fibroid sitting strictly in the muscles, not necessarily touching the lining and not really going outside of the uterus. And what do we do with those? And that's going to be the individualized decision. We're going to look at the patient again. How many are there? If there are a lot of them, I might want to take them out. How big are they? So the bigger they are, the more inclined I am to want to take them out, versus teeny tiny one, which is kind of like taking a sledgehammer, to use a time to put in a tiny little nail. If you're trying to take out a little 1 centimeter fibroid inside the muscle of the uterus, it's not going to help anyone. It's going to be a drastic surgery for very little benefit. You might look at the patient. So if you are 42 and we're talking about doing IVF, you don't really have 3 months to recover from fertility surgery, or from surgery. So your priority might be more along the line of doing IVF, unless you're going to do egg donation, in which case we've got that time, then we can take them out. If you're younger, if you make a lot of embryos, for example, or your egg reserve is very good, we might be more inclined to go and remove them. We're going to look at your medical history, your surgical history, your risk factors. And when it comes to your whole situation, have we been putting back embryo after embryo, and they're good quality embryo, and you're young and you're just not getting pregnant, then maybe I want to go take out those fibroids, because maybe they are impacting. If we're putting them in and you're having lots of miscarriages, then I might be able to make an argument for taking them out. So one patient's story with the exact same fibroid to another patient, we might manage very differently. So that's the sort of thing you need to discuss with your doctor about what for you makes sense. And you might start out with a doctor saying, let's not remove your fibroid, and you'll travel through your fertility journey and get to a point where they say, well, actually, maybe it's grown a little bit, maybe things have changed now because we've put back some embryos, you're not getting pregnant, or we've tried other treatments, you're not getting pregnant, and we might want to remove it at a later stage. So it's always important to remember that fertility is a journey. What I decide we need to do now is not necessarily what we would do in 6 months or a year's time. We have to look at how things evolve in your own personal story. And then the same thing goes for miscarriages. We cannot prove with evidence that fibroids cause miscarriages. I don't think any doctor would be able to leave a fibroid sitting in the middle of a cavity or squashing a cavity if the patient has miscarriages. If it's recurrent miscarriages, we can't find anything else. You probably are going to be more inclined to want to go and remove a fibroid, but it's not the rule. So it's not a case of if you have fibroids, you will have miscarriages, and it's not a case of if I remove the fibroid, I will stop miscarrying. We just don't have that evidence. The whole thing about if I take out a fibroid, am I going to cause any damage? Any surgery can leave scar tissue, and a myomectomy, where you're pulling out a fibroid, is going to leave a lot of scar tissue. So we take all the measures we can to avoid scar tissue, but there probably will be some. It is not more likely to cause you to have a miscarriage, and it's not more likely to mean you're not going to fall pregnant. So it's not going to be a magic cure, but it's not going to disadvantage you. So it's really important to have that individual discussion with your doctor. Where are my fibroids? What are my risk factors? What's happening in my fertility journey? And make that decision. So before I'm done with fibroids, are there any questions you want to do on that, or do you want me to run through cysts quickly?
I think let's run through cysts quickly. I'm sure it's not as complicated as fibroids, is it? Great. And then we can rather ask the questions later. So if anyone's listening and if you have a question for Doctor, please just put it in the comment section, and we can ask Doctor as soon as when she's done with her talk. Thank you. You can go on, doctor. Thank
So
you.
just to look at cysts, there's so many cysts, and I could talk for hours and hours on them, but they are the ones that are relevant to the patients who are listening to this. So when your doctor finds a cyst, it might be that you complained of pain, it might be a period or cycle that's a little bit out, you have your ultrasound, and your doctor finds a cyst. The first thing we want to do is try and classify what that cyst is. And the two first big groups we want to divide it into are the ones we are scared of, so the big C word, the ones that could be cancerous, and the ones that we call more benign and functional. So your cancerous ones we might identify with certain features on ultrasound. Some of the time they have a few sinister things we don't like when we look at them. We might do some blood tests and look for specific markers. There is no blood test that will tell you it is or is not cancer, but there are some that make us a bit more concerned, a little less concerned. And those ones we are worried about, most doctors are going to actually then send you to see a gynae oncologist who will do an assessment. Because if you are going to take out a cyst that could be cancerous, you want the cancer expert to do it. You don't want the general gynae to do it, take it out and go, oops, well, maybe I should have done X, Y, or Z, or shouldn't have spilled any of the contents. You want the pro to do it. So the first thing your doctor is going to do is check, do I think this cyst is dangerous? And if there's any concern, send you to see a gynae oncologist. The more common cysts that we are going to see are the functional cysts, so the corpus luteum cysts, which I'll run through, the dermoid cysts, and the endometriomas. So those are the ones that most people trying to get pregnant in their reproductive years are going to come along with. Functional cyst is corpus luteum cyst. What often happens is you ovulate, and most people will know you grow your egg in your little follicle, you ovulate that, and then that little follicle becomes a corpus luteum. And that is meant to basically produce progesterone, produces a little bit of estrogen, and it's maintaining everything and feeding your lining with all the right hormones ready to nourish an early pregnancy. Sometimes the signal goes a bit haywire, and that cyst can actually get quite big, and it can stick around a little bit longer than usual. It can cause pain, it can have a little bit of bleeding into it, and it can push your period out. So one of the things we look for when someone says, oh, my period's like 2 weeks late and I'm not pregnant and I'm not sure what's going on, this is unusual, we go and we look for one of those cysts. Some people then will then prescribe the contraceptive pill, which is a very common thing. Oh, you have a cyst, let me put you on the pill for a while, it will shrink it. It's not going to shrink it. That cyst is probably going to go away on its own. It usually just takes a cycle or two. We usually say have a look again in 6 weeks' time if it's not causing any symptoms. Contraceptive pill just stops you forming any new ones in the meanwhile, but it's not going to go and shrink it. So in terms of that cyst sitting there, it's usually not a dangerous thing unless you bleed into it, in which case that can be painful. A lot of the time we can manage that very conservatively with a bit of bed rest, a bit of painkillers. You don't need to go and operate and remove that cyst. The only other thing we worry about is a torsion, where an ovary twists. And that can be when you've got a cyst bigger than 5 centimeters, that thing goes and it twists. So just to clarify, cysts are basically collections. They can be solid, they can be fluid, but if you imagine a little balloon and it's sitting in the ovary, and the time we call it a cyst is when it is more than 3 centimeters or 30 millimeters on an ultrasound. So those little follicles that you have in polycystic ovarian syndrome are not cysts. Those are little follicles. It's just a very bad name made to confuse everyone.
Yes.
So we've got that functional cyst that will usually go away on its own. If it's still sticking around after a while, we might want to go and drain that or even remove it surgically. If you bleed and you're in severe pain, we can surgically drain that. If it twists, that's also an emergency surgery to untwist that ovary and try and save it and drain that cyst. That's one of the more common ones. It comes, it goes. We often find them on ultrasound. They disappear by the next by the next period, and they are not of much consequence. The two ones that we do need to speak about are the dermoid and the endometrioma. So I know someone will be talking soon about endometriosis. So just briefly, an endometrioma is endometriosis of the ovary. So it is a cyst that is full of all this chocolatey fluid, and we literally call it a chocolate cyst. So it's old blood, and it's one of the more severe forms of endometriosis. It's one of the few forms we can actually see on an ultrasound. You can have one or multiple in an ovary. They can be in both ovaries. And sometimes if you've got them in both ovaries, you can have what we call kissing ovaries, where they actually get stuck together. Endometrioma on its own is not necessarily going to cause a lot of symptoms. It's probably the endometriosis in general that is going to give you heavier periods, painful periods, difficulty falling pregnant, pain throughout your cycle, so chronic pain. So it might just be found incidentally. You might have no symptoms, or it might be found in the context of trying to fall pregnant, or in the context of, I just have period pain and I want an answer as to what's going on. So we've got a couple of options. Those cysts don't always need to be drained, and we need to see where you are, again, what your goals in terms of wanting to fall pregnant. If you are not wanting to get pregnant and it's not causing a lot of symptoms at the moment, we might put you onto something like Fibroid, which is a progesterone pill that you take, which we know is quite good at decreasing endometriosis, and it can slightly shrink those endometriomas and help manage your symptoms. You obviously don't want to be on that if you're trying to fall pregnant, because it's not licensed as a contraceptive, but you're probably not going to ovulate on it. So then we have the of, if we're trying to get pregnant and there are endometriomas, there is probably more severe endometriosis. We can then decide to either operate and surgically go in and clear the endometriosis and drain those endometriomas, or we can say, well, look, there's quite bad endometriosis, let's go and do IVF. And we can do IVF for those endometriomas still sitting there, as long as we can get to all the follicles. So again, it's an individual decision your doctor needs to discuss with you. Can I safely do IVF? What we don't want to do is poke an endometrioma with the needle and drain some of that fluid, because it's going to spill into the tummy. You can have a bit of a local reaction, and you can have quite a lot of pain, and even it can act as a little focus for infection. So we can either surgically manage it or go straight to IVF, depending on the size, the number, what the rest of your background is. We've got those two different options. And if we do it surgically, what we don't like to do is actually rip the whole cyst wall out. I don't know how many people watch Dr. Pimple Popper, but she always talks about removing a cyst wall, and that's quite an important thing. We always want to take a cyst wall out so there's nothing for that cyst to grow back. But if I pull an endometrioma cyst wall out, I'm stripping a whole bunch of those little potential eggs out with it. So we are very, very careful not to do that with endometriomas in someone trying to fall pregnant, unless they have an excellent egg reserve. Most of the time, we might take out a bit of the cyst wall, and we will use something called argon. A lot of people call it laser. It's not laser. It's a type of energy, and we actually just burn that cyst wall, so we don't cause damage to the rest of the ovary. We try to limit the chance of that cyst coming back. They do sometimes come back, and they can come back quite quickly, but at least we've cleared out the rest of the endometriosis, and plan for fertility after that. The other one to talk about is a dermoid, and a dermoid is probably one of the doctor's favorites, and probably something out of a horror story most of the time. Dermoid cysts are made out of all these little potential cells, so they can become hair, they can become sebum, so the gunk on our faces that we clean every day to not get pimples. That can be the stuff that we sort of squeeze out of pimples even. It can have bone, it can have teeth. So these cysts can really just be a little house of horrors full of weird and wonderful things. They've got quite characteristic appearance.
It's where you've always watched movies and say, oh, there's a twin.
Yeah.
So they would say, oh, it's like a twin. Okay.
Literally, you can have, I've seen bone, I've seen teeth, I've seen hair. If you Google removal of dermoids on the internet, you're going to see some pretty gruesome stuff. But that's probably why it's one of the doctor's favorites to actually remove, because it's quite satisfying to get it out. So these are quite characteristic on an ultrasound, and most of the time we know that's what we're dealing with. They're usually not cancerous. They can be very small, they can be very big, and they can sit there for years and never do anything. There were many times we did a cesarean for whatever reason, and you look at the ovary and go, oh, dermoid, take it out while we're there. If you are trying to get pregnant, again, we've got that whole conundrum. It depends how big the dermoids are. It depends if I can access the rest of the ovary or not. If you've got this big dermoid sitting in your ovary, that ovary is probably not going to be doing what it needs to do, or the tube might be a little bit distorted. So we might want to go and operate and remove the dermoid. Again, the same thing, we're going to pull the cyst wall out. It's very important for a dermoid, but it tends to cause a lot less damage than the endometrioma when we remove it. We try and get everything out in a bag, because obviously we don't want to leave bits of sebum floating around and hair, and we irrigate the whole pelvis very, very well to make sure we don't leave any of that behind. In terms of IVF, we can definitely do IVF if we can get to all the little follicles, but again, you just can't pop that dermoid and leak the contents all over the tummy. So it's something you need to be very well counseled about, that you might have eggs or little follicles left undrained, potential eggs left unharvested with IVF, just because we don't want to go too much near that dermoid. Dermoids don't often cause a lot of symptoms unless they get super big and then they want to twist. So they're not the most common cyst that's going to twist and cause torsion. Neither is an endometriomics. They're usually quite stuck down, sticky, and a lot of scar tissue. But they can theoretically do that, in which case that would be an emergency surgery to drain them. So when it comes to the cysts, the endometriomas and the dermoids, you've got the options. Do we go and do IVF, or do we go and operate and actually remove them? And those are the really important categories of cysts that we deal with in reproductive aged women and women who want fertility treatment or wanting to be pregnant. So I know that went on a lot longer than I was supposed to speak for. Sorry about that, but do we have any questions?
Yes, we do have questions, but you really go and you give us all of it, so we really appreciate it. Don't feel bad for talking long. You really, yeah, we'll never be able to get that type from anyone else. I've got one question that just came through from Chronicles of Infertility. Not sure if I missed it. How long does it take for fibroids to come back after myomectomy?
Depends. It can vary. Most of the time, I don't expect them to come back, well, not that exact fibroid. It's often that you've got tiny little microscopic fibroids that are growing, and they're going to grow over time and be revealed. I've seen a patient this week who I removed nice big fibroids for about 1.5 years ago. She's come back now with COVID. There's been issues. Come back. She has new big fibroids that I now have to remove. So every patient is going to be completely different, and you can't predict when the fibroids are going to come back. It depends if some of them were left behind and if you opted not to remove them all. Otherwise, you might be little small new ones that have grown. Some patients have a fibroid out and they never have a problem again, and they're lucky. So it really does vary. There's no hard and fast rule.
Yeah, there's other questions, but after reading these questions, seeing the questions, and after listening to you, actually explained all of this, but because, so if asked, let me rather just say it, must fibroids be removed surgically? So you actually have gone through that, but you can answer.
So just in summary, no, they don't always need to be removed. It depends on what the symptom of the fibroid is, what your priority is. So managing symptoms, getting pregnant, miscarriages, pressure symptoms. And then you've got the options of medical treatment to control that, the various surgical options, or the less invasive options like the uterine artery embolization, or even the most extreme hysterectomy. So they don't always have to be. They're sitting there, you've got no symptoms, they're an incidental fine, then leave them until they're a problem. They might not ever become a problem.
Okay, great. There's another one. After op, does it increase your chances of conceiving after removing fibroids?
So it depends where they are and how many they are. If it was sitting slap in the middle of a cavity, it's going to improve your chances of falling pregnant. Because imagine that little embryo trying to find someone to implant, and it implants in the area just over that fibroid. That's not normal tissue. It's not going to be able to implant well there. We also think the fibroids secrete a lot of factors that cause abnormal contractions, abnormal lining, and so you tend to not fall pregnant when they're squashing and affecting your lining. So depending where it is going to make a difference. Sometimes you might have a big fibroid and your poor little tube is being stretched straight over that, and if we can remove that pressure, the tube might be a little bit better at doing its job. But not every fibroid, when removed, is going to improve your chances of falling pregnant, and that's why your doctor needs to be able to explain to you why they want to take that fibroid out if they want to remove it, or why they're happy to leave it in if that's the case.
Okay. One last one is, when is it safe to try again after having it removed?
3 months afterwards, unless the doctor said they're worried that they want to do a hysteroscopy 6 weeks later and just see that things are fine, but you would know that straight after the surgery. So if your doctor's worried there might be some scar tissue or they might have damaged the lining a little bit, they want to check and repair that, they might say another procedure in 6 weeks just to have a look and see. But generally the rule is 3 months.
Okay. We've got one last one that's just come in. Is there medication to shrink fibroids? So, and we've also gone through this, yes?
So there are the GnRH analog injections that we can use to try and shrink them, but it is not a long-term thing. It's something we usually do to buy time until surgery or to alleviate symptoms, or if I'm worried someone's going to bleed, during surgery. And then there is a drug that we don't have access to in South Africa, and they have in fact pulled generally from the market at the moment until they have more data, called Euler Crystal, which has also been shown to be quite effective at shrinking fibroids. But unfortunately, we don't have that at the moment.
Okay, great. Thank you, Dr. Oosthuizen. Thank you, everyone, for joining us. And we just want to say thank you for taking the time out and actually going through all of this with us in so much detail. I'm sure so many of us, and I think there's been so many women I've been seeing. We've had numerous women actually, looking and joining in because it's quite a big thing. And I know there's a lot of women that suffer with this. So
Yeah.
thank you for the information. And thank you for joining us always and taking the time out for us. Thank you.
Always happy to chat.
Okay, perfect. Have a great evening, Doctor. Thank you. Bye.
Bye.